All right, get ready, everyone, because we are about to take a deep dive into the world of Acinetobacter.
And a deep dive it will be.
You know, these bacteria are becoming a real challenge in healthcare settings these days.
Oh, absolutely.
So we're going to use the Principles and Practice of Clinical Bacteriology, that's second edition, to guide us through this.
Excellent choice.
It's like our roadmap through the world of Acinetobacter.
A roadmap for medical microbiologists like us.
Exactly.
Yeah.
So we can get those key need-to-know insights.
The essentials.
Okay, so let's start with the basics. What are we even looking for? How do we spot these tiny troublemakers under a microscope?
Well, you'll see that Acinetobacter are aerobic gram-negative bacteria.
Okay, so far so good.
They're often rod-shaped, but sometimes they can actually look a bit more like kochi in pairs or chains.
Oh, interesting. So they're a bit more shapeshifters than we might think.
They like to keep us on our toes.
They do. And their name, it's kind of funny. Acinetobacter actually means unable to move.
Right.
But there's this interesting twist. They actually exhibit a kind of like twitching motility.
You got it.
So they're not technically non-modal after all.
It's a bit of a paradox, isn't it?
It is.
Yeah.
I wonder, does that play a role in their ability to spread and colonize surfaces? This twitching.
That's a great question.
We'll have to explore that further.
Now, back in the lab, if you're trying to pin down Acinetobacter,
Okay.
remember that they're oxidase negative, catalase positive, indole negative, and nitrate negative.
So a lot of negatives to keep in mind.
Yes, but very important negatives.
Okay, got it. Anything else about their classification that we should keep in mind? I think the book mentioned something about the taxonomy of Acinetobacter being a bit complex.
You're right. Their classification has seen a few revisions over the years, but the key takeaway is that A. baumannii has emerged as the main culprit.
The one to watch.
The one most frequently associated with these nosocomial infections we keep hearing about.
Ah, yes, those healthcare-associated infections that always seem to crop up.
Especially in the most vulnerable patients.
Exactly. Speaking of which, the source material really highlighted Acinetobacter's ability to survive in all sorts of harsh environments.
They're remarkably adaptable. You find them in soil, water, and even thriving in hospital settings.
Wow, so they're not picky at all.
Not at all. They are masters of adaptation.
But what makes them so good at surviving in, let's say, a harsh hospital setting?
Well, one of their survival secrets is their incredible tolerance to desiccation.
Desiccation. So basically being able to survive in dry conditions.
Precisely. They can hang out on surfaces for a surprisingly long time.
So like equipment, bed rails, things like that.
Exactly. Even when things seem dry, they could be lurking there.
Wow. And that, of course, makes it much harder to control their spread.
Exactly. We call them opportunistic pathogens because they're just waiting for the right chance to cause an infection.
So it's not just about where they are, but their patience.
Their ability to seize the opportunity.
Okay, so let's get into the nitty-gritty here. How they actually cause these infections. What tools are they using?
They have a whole arsenal of virulence factors, you could say.
Okay, lay it on us.
Well, for starters, they have this polysaccharide capsule, which acts like a shield, helping them evade our immune system.
Oh, clever. So it's like they're wearing camouflage.
You could say that. Then they have fimbriae, which are these tiny hair-like structures.
Fimbriae. Oh.
Yes, they use these fimbriae to attach to human cells, almost like grappling hooks.
Oh, wow. So they're really coming prepared.
They are. And of course, we can't forget about lipopolysaccharide, or LPS.
LPS, right.
It's part of their outer membrane, and it can actually trigger a really powerful immune response in the body, sometimes even leading to sepsis.
Okay, so they're not playing around.
Not at all.
They're coming in ready for battle. But how does all of this actually play out in patients? What does an Acinetobacter infection actually look like?
That's the tricky part. Acinetobacter infections can manifest in so many different ways.
Okay, so they're masters of disguise.
Exactly, making diagnosis a real challenge.
Okay, well, give us some clues. What should we be on the lookout for?
Well, the most common presentation is going to be respiratory tract infections, especially in those patients who are on ventilators.
So pneumonia is a big concern.
A major concern. And these infections can be very severe, leading to longer hospital stays and sometimes worse outcomes.
That's definitely something to watch out for.
Absolutely. Another common presentation is bacteremia.
Bacteremia, so that means the bacteria have entered the bloodstream.
Yes, and this can be life-threatening, especially for patients who are immunocompromised.
So early detection is key here.
Absolutely. And then there's urinary tract infections, which are very common, particularly in patients with indwelling catheters.
So these Acinetobacter really seem to have a knack for finding those most vulnerable patients.
They're opportunistic, so they're always on the lookout for any weakness they can exploit.
It's like they have a sixth sense for vulnerability.
In a way, they do.
All right, so let's say we have a patient and we suspect an Acinetobacter infection. How do we know for sure? What tools do we have in the lab to make the diagnosis?
Well, that's where your expertise as medical microbiologists comes in. Identifying and characterizing Acinetobacter accurately is absolutely critical for effective management.
Okay, so walk us through it. What's the gold standard?
Traditional culture techniques are still the foundation. We need to grow these bacteria to really understand them.
So no shortcuts in the lab.
Exactly. But remember, they can be a little finicky.
Oh, really?
Yes. So we have to be mindful of their specific growth requirements to get a reliable result.
Okay, so we need to be precise in our methods.
Precise and patient.
Okay, got it. Now, when it comes to pinpointing the specific species, especially during an outbreak, molecular methods are becoming more and more crucial, right?
Absolutely. They allow us to track these bacteria more effectively and understand how they spread.
I remember the source material mentioned a few different molecular methods. Can you refresh our memory on those?
Sure. There's ribotyping, where it analyzes patterns in the ribosomal RNA genes.
Okay, we're ribotyping.
Then there's pulsed field gel electrophoresis, or PFGE.
PFGE, that one rings a bell.
And finally, amplified fragment length polymorphism, or AFLP, which looks at variations in amplified DNA sequences.
So many acronyms. But it sounds like we have a whole toolkit to help us play bacterial detective.
We do. Each method has its strengths and weaknesses, but together they give us a comprehensive picture of what we're dealing with.
Out of all these methods, which one do you find most useful in your everyday practice?
PFGE is often considered the gold standard. It's very reliable and gives us a high level of discrimination between different strains.
So it really helps us get down to the nitty-gritty details of the outbreak.
Exactly. It helps us connect the dots and understand how the infections are spreading.
It's amazing how much information we can get from these tiny organisms.
Truly remarkable. And remember, knowing your enemy is the first step to victory.
Well said. We've covered a lot of ground already, from their unusual motility to their impressive survival strategies.
And we're just getting started.
Stay tuned as we delve deeper into the world of Acinetobacter. We'll be back after a short break to explore their epidemiology and discuss how we can prevent and control their spread in healthcare settings.
Can't wait. Welcome back, everyone. Before the break, we were really getting to know Acinetobacter on a microscopic level.
Exploring all their little quirks and secrets.
Right. Now let's zoom out a bit and take a look at the bigger picture, their epidemiology.
Epidemiology. So we're going global, mapping out Acinetobacter hotspots around the world.
Well, not exactly. Acinetobacter species are, they're pretty ubiquitous.
Ubiquitous, so they're everywhere.
Pretty much. Soil, water, even on healthy people.
Okay.
But the ones that really cause trouble, especially abomania, they're mainly a problem in hospitals.
So it's less about geography and more about specific environments.
Exactly. Hospitals are their preferred battleground.
Their domain.
You could say that. The
Yeah.
community isn't a major source for the types of Acinetobacter that cause the most serious infections.
Okay, that
Yeah.
makes sense.
So hospitals really act as the main stage for their spread.
So how do they actually spread within a hospital? We talked about their ability to survive on those dry surfaces. Does that play a role?
Absolutely. Remember that incredible tolerance to desiccation we discussed.
Hard part to forget.
Right. Well, that means contaminated equipment like ventilators, catheters, anything really.
Becomes a potential source.
They can become silent carriers, just waiting to spread those bacteria.
Wow, so they're hiding in plain sight.
In a way, they are. And then, healthcare workers, even with the best intentions,
Of course.
they can inadvertently transfer bacteria from those surfaces to patients.
Especially those vulnerable patients we were talking about.
Exactly. It's a constant challenge to stay one step ahead.
It sounds like it.
Yeah.
So important then to understand their epidemiology so we can put those effective infection control measures into place.
Absolutely. Knowledge is power when it comes to preventing the spread of these tricky microbes.
All right, so let's talk about those control measures. What can we, as medical microbiologists, actually do to combat these tenacious microbes?
Well, it all starts with the fundamentals.
Back to basics.
Exactly. Good hand hygiene.
Hand hygiene, always important.
Can't emphasize it enough. We also need to be extremely diligent about decontaminating the environment.
So like those frequently touched surfaces, equipment, things like that?
All of that. Constant vigilance is key.
Constant vigilance, all right.
Right. And then there are surveillance programs.
Surveillance programs, okay.
By closely tracking Acinetobacter infections, we can identify outbreaks early on and intervene before they spiral out of control.
So it's like being a detective, constantly looking for clues.
Exactly. Connecting the dots and using that information to stop them in their tracks.
Love it. But even with the best prevention strategies in place, some patients will still get infected, right?
Unfortunately, that's the reality we face.
And that brings us to the challenge of antibiotic resistance.
The elephant in the room.
Acinetobacter, especially A. baumannii, they're notorious for their ability to develop resistance to multiple antibiotics.
They're masters of adaptation, remember?
Oh, I remember.
Yeah.
It's like they're always one step ahead.
It can feel that way sometimes. We're seeing increasing resistance to even our last resort antibiotics like carbapenems.
That's a scary thought.
It's definitely a concern.
So what's the game plan then for treatment in those cases when resistance is a factor?
It's a complex situation for sure.
Okay.
While carbapenems are still often considered a first-line option, we need to be very aware of that growing resistance.
Right.
Sulbactam, a beta-lactamase inhibitor, has shown some promise.
Sulbactam, okay.
And often combination therapies are necessary to really boost effectiveness.
So it's not a one-size-fits-all approach.
Definitely not. It requires a careful evaluation of each individual case.
So many factors to consider.
Absolutely. When choosing a treatment, we need to think about the patient's overall health, the severity of the infection, any underlying conditions that might make them more susceptible.
It's like a puzzle, putting all the pieces together.
It is, and it often involves supportive care measures as well, like respiratory support for those with pneumonia.
Right.
In addition to the antibiotics, of course.
So that takes a real team effort, not just us in the lab, but clinicians from all specialties.
Absolutely. It's all about collaboration.
And communication.
Yes. Communication is paramount.
Making sure everyone's on the same page.
Exactly. We, as medical microbiologists, we play a crucial role in guiding those antibiotic choices.
Interpreting those lab results, monitoring for any signs of resistance.
We're the eyes and ears on the ground, providing critical information in this fight against these truly challenging pathogens.
Well, I think we've covered a lot of ground today, from the basic characteristics of Acinetobacter to their complex epidemiology.
We've talked about the challenges of antibiotic resistance, the importance of infection control,
and the ever-evolving landscape of treatment options.
It's been a whirlwind tour, but now it's time to put your knowledge to the test. Are you ready for some exam-style questions?
Challenge accepted. Bring it on. Okay, medical microbiologists, it's time to put that knowledge to the test. Are you ready for some exam-style questions?
Let's do it.
All right, here comes your first question.
I'm ready.
Which of the following is not a characteristic of Acinetobacter species? Is it A, aerobic, B, gram-negative, C, oxidase positive, or D, non-modal?
Okay, let me think back to those key identifying features.
Take your time, no rush.
All right, I think I've got it.
Okay, what's your answer?
I'm going with C, oxidase positive.
And you are absolutely correct. Acinetobacter are oxidase negative.
Ah, of course.
That oxidase test can really help us distinguish them from other similar-looking bacteria.
Definitely a key test.
Okay, ready for question number 2?
Hit me with it.
What is the most common mechanism of resistance to carbapenems in Acinetobacter baumannii? A, efflux pumps. B, aminoglycoside modifying enzymes. C, production of carbapenophyses. Or D, alterations in penicillin binding proteins.
Okay, so we're talking about those tricky resistance mechanisms.
Exactly.
Let me see, thinking about carbapenem specifically.
Yeah. All right, got your answer.
I'm going with C, production of carbapenemyces.
You are on a roll. That's absolutely right.
Yes. Carbapenemys production is definitely a major concern when it comes to treating these infections.
It's becoming more and more prevalent, making treatment a real challenge.
Absolutely.
Okay, on to question number 3. Which of the following typing methods is considered the gold standard for Acinetobacter strain typing? A, biotyping. B, antibiogram. C, pulse field gel electrophoresis, PFGE. Or D, ribotyping.
Okay, thinking back to our bacterial detective tools.
Which one gives us the most detailed information?
The gold standard, you say. I'm going to have to go with C, PFGE.
And you are right again. Pulsed field gel electrophoresis is our go-to method for a reason.
It's so reliable.
It gives us a high level of discrimination between strains, helps us track outbreaks, really understand transmission patterns.
PFGE is definitely our best friend when investigating those complex outbreak situations.
Couldn't agree more. Okay, 2 more questions to go. Question 4, what is the primary reservoir for Acinetobacter baumannii? A, soil, B, water, C, hospital environment, or D, healthy individuals?
Thinking about where we see the most Acinetobacter infections,
Where do they really thrive?
it's got to be C, the hospital environment.
Yes. Acinetobacter baumannii is a nosocomial pathogen. Loves those hospital settings where it can spread easily among vulnerable patients.
Makes those infection control measures even more crucial.
Absolutely. Okay, last question. Here we go. Which of the following antibiotics is typically considered a first-line agent for treating Acinetobacter baumannii infections? A, ceftazidime, B, ciprofloxacin, C, imipenem, or D, gentamicin?
All right, thinking about treatment options here.
What's our go-to choice? Keeping in mind that resistance is always a factor.
Okay, I'm going to go with C, imipenem.
And you are correct. Carbapenems, like imipenem, are often our first choice, but we always have to be mindful of that increasing resistance.
Always a concern.
Absolutely. Well, you aced those questions. Congrats.
Thanks. It was a good review.
We've covered so much ground today, from those quirky characteristics of Acinetobacter to their incredible adaptability and those sneaky virulence factors that make them such formidable opponents.
We've talked about the diagnostic challenges, the critical role of infection control, and those ever-evolving treatment strategies.
It's clear that the fight against Acinetobacter is far from over, especially as antibiotic resistance continues to rise.
Absolutely. It's an ongoing battle.
So to all our fellow medical microbiologists out there, keep learning, keep asking questions, and most importantly, keep fighting the good fight against these challenging microbes. Until next time, stay curious.